I warmly welcome you all to the webinar today. The topic is Mpox update from diagnosis to management. Today's CME is organized by the CPD Committee of College of General Practitioners of Sri Lanka. And I thank the college and also the CPD committee for organizing a much needed webinar. Our speaker today is Dr. Menaka Ranaweera, MBBS, postgraduate certificate in medical education, postgraduate diploma in medical microbiology, MD in medical virology. Currently, she is working as a senior registrar in medical virology at IDH Angod. Over to you, Dr. Menaka.
Hi, thank you, Dr. Satish. Can I just check in whether you can see my slides moving as well?
Yes, Doctor.
Okay. Right, so let's take a start then. So for the next 30 minutes or so, I will talk about Mpox regarding some of the basic virology, right up to the diagnosis and management. And if there's any questions, we can discuss them afterwards. But if you do have questions, you can put it in the chat when we go along, and then we'll take them up at the end. I thought we will start with a case history. So imagine you have this kind of a person sitting in your GP practice, and what you would do to manage. So we've got a 42-year-old businessman who's based in Colombo, who had recently returned following a trip to London, Singapore, and Dubai. And at the moment, he's been experiencing fever, muscle aches, which he has initially attributed to being jet lag. But then later on, he has noticed a few red spots on his forehead, chest, which has become painful. And now there are some lesions on his palm as well, which is making it difficult for him to work. So let's consider some that you need to know in order to manage this person. So during the rest of the presentation, I will be discussing about the differential diagnosis, how significant this travel history is, how do we confirm the diagnosis, how do we manage this patient and his contacts, and what is the likely outcome for this patient. So first, let me start with a brief history about Mpox. It was first discovered in 1958 among some laboratory monkeys, hence the name monkeypox. But the first human case was discovered in 1970 in a 9-month-old in Democratic Republic of Congo. Since then, there has been more cases reported in African countries. But the first case in the United States was reported in 2003. Again, this was a laboratory incident following some imported animals. Then from about 2010 to 2019, this disease was slowly spreading in Republic of Congo and Nigeria. More than 18,000 cases have been reported. But things changed in 2022. As you can all remember, in May 2022, the cases started emerging in non-endemic countries. So UK, Australia, Canada, Belgium, United States. And this is the time when this disease got global recognition, and people started doing more research about it, and a lot of interest came in, as we would expect. But this outbreak sort of slowly died down. But in December 2023, monkeypox virus clade 1 was starting to spread again in Congo. And it has been steadily increasing, and again, other African countries as well. So that in August 2024, again, WHO declared this as a public health emergency of international concern. So this is a bit of the background regarding how the things are as it stands. So if you look at the global Mpox cases from January 2022 to 30th September 24, total laboratory confirmed cases is 109,699. Confirmed deaths 236, and it has been reported over 123 countries. In Sri Lanka, 4 cases had been reported. Although laboratory confirmed cases are this, there may be the suspected cases may be higher. Now let's look a bit at the virology of this. So monkeypox virus, so that's the name still is the monkeypox virus. It's the disease that was renamed as Mpox. Now it's really important recognizing what is the family that it belongs to, because it tells us then a bit of the characteristics of what we can expect. Because as you know, initially monkeypox was more common in animals. So now, since it has become more prevalent in humans, it's important for us to have an idea regarding what kind of characteristics that we can expect. So it's belonging to the Poxviridae family, Poxviridae subfamily, and genus Orthopox virus. And some of its relatives are the vaccinia virus and variola virus, which used to cause smallpox. So monkeypox virus is an envelope virus. This again becomes important when we know these characteristics. It will help us figure out things like when we are thinking about our infection control measures, we know with envelope virus, it is easier to make them inactivated with certain disinfectants. And it is a DNA virus. Again, that tells us that this is actually a very stable virus and that can survive outside for a longer time. And the entire life cycle is completed within the cell cytoplasm, which is slightly unusual for the DNA viruses. But this also means that there is no latency phase for this particular virus. Now, which is something of interest, is this differences in the clades. So there are 2 different clades that are known for this monkeypox virus. So it is a zoonotic virus. The exact animal reservoir is unknown. What I have shown is some of the possible culprits. So as I mentioned, there are 2 different clades, clade 1 and clade 2. And clade 1 was originally seen in Central Africa, whereas clade 2 was seen in West Africa. And during the 2022 outbreak across the globe, it was clade 2b that was most prominent. And the current outbreak in the Democratic Republic of Congo is the clade 1b. So this becomes important because if you can see, the mortality is different. So now main concern is the spread. The fear is that clade 1b may spread out of Africa into its non-endemic countries. And that is the risk that we are worried about. Now, with our patient, had a travel history to London, Singapore, and Dubai. So this kind of, this map actually shows you the different clades that have been found from January to October this year. So these countries are the ones which have recently have clade 1 reported. So Germany, Sweden, India, Thailand, and Pakistan. So that becomes a bit of an important thing because otherwise clade 1 was generally confined to Africa. So having an idea regarding this, what kind of a spread is there is important. Okay, so if we look at the clinical presentation, Mpox is generally a very mild self-limiting illness. However, severe disease can occur even with life-threatening complications in those who are immunocompromised. Usually, there is the mean incubation period is mentioned as 2 to 21 days. You may see slightly different numbers, sometimes 6 to 13 days, but as on average, we can take it as a 2 to 21 days with a prodromal phase of 1 to 5 days with symptoms of fever, lymphadenopathy, myalgia, malaise, headache, and then of course the eruptive phase, which is where you get your rash and these lesions. Person is usually infected from the start of the prodrome until the rashes have completely healed. Generally, this is on average, the rash tends to start off in the face going towards the trunk and limbs. However, during the global outbreak, when clade 2b was prevalent, there were differences in this kind of pattern. So it's usually the rash was more prominent in genital, anogenital, and perioral and oral areas. And also this non-uniform progression of lesions was there. So generally what was associated with Mpox previously was that there was uniformity in the lesions. But now what we are seeing is different types of lesions can be present at the same time. So generally, following the incubation period, the prodromal features, symptoms, you are getting macules, and there is a progression from macules, papules, vesicles to pustules, then scabs, and you get your V-epithelial section. As I was saying, lesions may occur in different stages simultaneously. So the other thing to consider is complications. So there are other associated symptoms based on the location of the lesions as well. So it's very important to fully examine the patient to find out with good lighting to find out exactly where the lesions are, and also to ask the patient regarding some of these symptoms that they may be experiencing. Sometimes patients may not be very forthcoming regarding these symptoms, and some of the hospital admissions are actually in those without severe diseases because of pain due to things like the proctitis. So because of that, it's very important we have a good idea regarding exactly the symptom presentations. And of course, there are other complications associated with severe disease, things like necrotizing skin lesions, bacterial superinfection, and there have been other organ involvement, pneumonia, encephalitis, myocarditis, hepatitis, multiple organ failure as well. Now, these severe infections disease is more common in immunocompromised patients. Now, with our patient, we always have to consider whether is this actually Mpox or can it be something else. So these are some of the differentials that we need to consider. So chickenpox is one of the most commonly similar presentation. So past history of chickenpox, vaccination history, these things need to be explored. HSV, enterovirus, molluscum contagiosum, and again, certain bacterial infections also should be considered as a part of our differential diagnosis. Okay, so imagine this is the presentation of our patient. So he's got some lesions of different morphology. in his palms, face, and back as well. So how are we going to collect samples from these lesions? Now we have the option of collecting blister fluid. Should we collect that? And should we just swab one lesion, or should we get swabs from multiple lesions? Generally, the specimen preferred is lesion swab using a synthetic swab. Of course, you can take crust or lesion roof as well. Better to take samples from multiple lesions. Now, blister fluid is not very well recommended because there have been incidences where healthcare workers have sustained needle-stick injuries trying to collect blister fluid. Therefore, it's not really recommended to try and collect that. Blood again is not preferred due to the short viremia phase. And better to transport in VTM in our setting, although it can be transported in dry as well, as it's a DNA virus and it is quite known to be quite stable. Even transporting it in dry as a dry swab is acceptable, but then need to think about the storage temperature conditions. For a short time, it can be stored at 2 to 8 degrees, but for long-term storage, should be kept at -20. And again, if you're keeping dry swabs, again, should be stored at -20. And then, of course, need to be accompanied with a duly filled request form. So here I have just put the MRI request form, which is available from the site. And what PPE to use when you're collecting samples. So this is essential to safeguard your own protection as well. So what investigation should we do? The main diagnostic test is real-time PCR. We can do testing for orthopox virus PCR as well as specifically for monkeypox virus PCR. Both are available here. Then that is the diagnostic test of choice. Then sequencing is important, which is not available at our setting yet. But if we want to figure out what type of clade, whether it's clade 1, clade 1B, clade 2B, it is important to be able to do sequencing as well. Electron microscopy, not really for a diagnostic purposes. Isolation in cell culture, again, not in a clinical setting because a lot of the labs do not have cell culture facilities, and also due to the long duration, it is not considered turnaround time. It's not a preferred test. Then serology, it's not generally for diagnosis purposes, not used for that. And there's also risk of false positivity as well. As I mentioned about the complications, it's important to do supportive tests. And then this is really important, STI screening, including HIV 1 and 2, because especially if the patient is immunocompromised, that we can expect severe disease. So it's very important that disease screening is done. Now, what about our patient? Is our patient at risk of severe disease? Generally, severe disease is expected in certain risk groups. So neonates, young children, pregnant mothers. And when I say HIV, it's actually patients who are having a CD4 count less than 200 that are at risk. And those who have undergone solid organ transplant, because again, they are immunosuppressants. We actually incidentally had a patient, neonate, who had quite a severe disease. From one of the 4 cases that was detected in Sri Lanka, one of them was a neonate. Even developed myocarditis as well. So definitely we can expect severe disease in neonates. So how do we manage our patient? So the mainstay of treatment is actually supportive care. As I mentioned, these lesions can be very painful. So therefore, we need to make sure appropriate analgesia is given, especially if lesions are there in a genital area. So stool softness, sitz bath can be recommended, lidocaine gel, this can be recommended. Then, if there is evidence of bacterial infection, of course, antibiotics should be given. Antivirals, they don't generally can be given in cases of severe disease. Unfortunately, these are not available in Sri Lanka. Tecovirimat or brimcidofovir. These are two of the more commonly used drugs. So tecovirimat is the first choice, basically, that is given. And this drug can be given for those who are having severe disease. But the problem is it's not, the clinical efficacy has not been proven. So these both drugs have been approved for license for smallpox, but still not for Mpox. So there is a phase 3 randomized trial going on for tecovirimat. There has been a trial in Republic of Congo where clade 1B is prevalent, where there is evidence or suggestive that tecovirimat doesn't necessarily cause a huge clinical effectiveness, but still for clade 2B, results are pending. Then again, sometimes immunoglobulin have been used. Again, not a lot of evidence for this. Then, of course, infection prevention measures are important. So in our setting, generally the patients have been managed at IDH. So isolation precautions are necessary. So single room, contact-based precautions until all lesions are healed. So this gives a bit more details regarding some of the drugs that can be used. So as I was saying, tecovirimat, the STORM trial that is underway. So that will provide us with more definitive evidence regarding the effectiveness of this drug. So how to manage the contacts? Okay, so let's go back to our patient. So imagine that our patient has been traveling while the patient is having symptoms, has been traveling in the middle of the airplane and also had gone through a very congested airport and then come home 2 days ago. And at home, there is his wife who is pregnant and there's a 5-year-old son. So a lot of exposures. And of course, as the healthcare provider, you have also been now exposed. How do we manage? So we need to know certain information regarding this. We need to know period of infectivity. So as I mentioned, the period of infectivity starts at the beginning of the prodrome until the scabs of all the lesions have fallen off. Then we need to consider transmission. So known transmissions, animal to human. So this was what was seen earlier in Africa with contact with, so with animal to human contact with infected lesions, bodily fluids, bites, scratches, respiratory droplets. But what we are interested in is human to human transmission. So contact with infected lesions, bodily fluids, infected materials such as bedding, linen, and then also within households as well. So in certain African settings, this has been very much more seen where there is congested living conditions. Then the risk of transmission between household contacts is much higher. And then in the hospital, sort of the occupational settings, it is generally what has been seen is this needle stick injuries. In situations even where PPE hasn't been worn very well, again, a lot of occupational hospital setting infections have not been seen. And then, of course, vertical transmission. So no airborne transmission is there. So that means for our patient, we don't need to think about contact tracing for those who have been in the airplane or contact in the airports. We don't have to think about it. It's usually the close physical contact that is needed for infection to occur. So as the healthcare provider, you're probably safe as well, especially if you have, even without any PPE at this stage, it's very unlikely for transmission to occur. Unless, of course, you have been handling the lesion without any gloves. Then vertical transmission is there. So if there has been sexual contact with the wife, then of course, if the wife gets the infection, can transmit to the unborn child. So what can we do for post-exposure prophylaxis? Now, where vaccines are available, so 3 vaccines have been described. So this is modified vaccine and Bavarian Nordic vaccine. It's called commonly Jynneos vaccine. It is given intradermally or subcutaneous, 2 doses, 4 weeks apart, and the efficacy rates have been shown to be around 66 to 86%. And 2 other virus vaccines, smallpox vaccines, which have also been found to be effective against Mpox and approved for this indication as well. So as part of post-exposure prophylaxis, so these are the USA, the CDC recommendations that I'm now discussing. Jynneos vaccine is recommended in settings where there is known or presumed exposure to monkeypox virus, and it should ideally be administered within 4 days. Can be given up to 14 days. And of course, the incubation period comes into play here. The earlier you give, the better. Sometimes you may get the disease, but the severity may be less after having the vaccine. Can we give it in this pregnant patient? Yes, it is not contraindicated. However, the risk and benefits needs to be discussed. Then, of course, the vaccine is available as pre-exposure prophylaxis as well. 2 doses, 4 weeks apart. It can be given for healthcare workers as well, who are at high-risk areas. Then those who are traveling to high-risk areas can be given as well. But the main indication at the moment is those who are at risk, and these are the indications that have been mentioned. This is again from the CDC recommendations. Anyone with these risk factors is eligible for this vaccine, and there is no need to disclose in terms of what category they fit into to make sure that the vaccine will be taken up more. So what do you think will happen to a patient? So generally, Mpox is a self-limiting disease with recovery in about 4 weeks. Scarring can occur in about 5 to 40%. However, in those with genital lesions, scarring, strictures, paraphimosis, fistula, these kind of complications can occur. So these need to be monitored and managed if present. If ocular involvement is there, then it's very important an ophthalmologist is contacted very early on, because there is a risk of partial vision loss and blindness. Again, this mortality rate. So clade 1 is happen to have a higher mortality rate than clade 2, but it's also important to recognize that clade 1 was more prevalent in Congo, where healthcare facilities are not always high resources, and also the healthcare seeking behavior is different. So that also need to be taken into consideration when this case fatality rate is considered. So what we saw in the 2022 outbreak, rest of the globe, when it came globally, the mortality rate was actually less than 0.2%. So we can expect very good prognosis for our patient. So, in summary, Mpox is primarily transmitted through close skin contact. It's mostly a self-limiting illness. However, severe illness can be seen in those who are immunocompromised, especially those who are having HIV or AIDS. HIV, especially with the CD4 count of less than 200. And mainstay of management is supportive care. So prevented through behavior change and vaccines. Neither of the vaccines are unfortunately available here at the moment. And this is important. So Mpox is an evolving global health threat. Therefore, as clinicians, we should be able to recognize it. Okay, so that's the end of my presentation. I would be very happy to take any questions at the moment.
Thank you, Doctor. There are a few questions. I'll read it to you. First one is, Doctor, you are here. You can hear me, yeah?
Yes.
Hello. Yeah.
Yes, I can hear you.
First question is, how to differentiate Mpox? How to differentiate Mpox from chickenpox and hand-foot mouth disease?
Okay, so we need to consider the if there is any history of chickenpox, that can be helpful for us to know, and also we can also think of the epidemiological side. So if there's any contact history,
Yeah.
that can be considered. And it's sometimes it's a bit difficult to, but generally chickenpox, you will not get palms and soles are not always affected, whereas in Mpox it is more likely to be affected. So again, the mucosa being affected in Mpox, that is another thing. But sometimes, if there is a doubt, then testing is one of the most important things. And again, hand, foot, and mouth disease also, at the moment, we can also consider the patient population as well. Whereas what kind of age range that we are expecting these diseases, and looking at the epidemiological things, that is helpful when we are considering differentiating.
Yeah, the next question is, Doctor, how long to isolate once infected?
Okay, so here we have to think about the period of infectivity, as I mentioned. So it starts from prodrome up to until all the lesions have scabbed off. So usually this might take about 2 to 4 weeks. So the isolation we would generally recommend up to until all lesions have healed.
There's one more question, Doctor. If someone had take the smallpox vaccine 30 years ago, are they still immune against the Mpox?
Okay, so it's difficult to answer this definitely, as I haven't seen exact evidence on this, but generally what is seen is that there is a cross protection. So for example, I can mention, this our case of Mpox we had of our neonate. The grandmother had had the vaccine, and although there was a lot of contact with the patient, she herself didn't develop. So I'm just telling one example here, but there is cross protection, but the extent of it, I'm unfortunately not able to quantify actually, but very possible to be protected.
Thank you, Doctor. That ends the question session. Thank you very much for an informative lecture, a timely lecture. And I also thank the CPD subcommittee of the College of General Practitioners of Sri Lanka for arranging this informative lecture, and also our supportive staff for conducting this webinar. Thank you for the participations as well. Thank you, everyone. Good night.